So, the topic for today's discussion is a new type of multiple sclerosis. And when I told the topic to Dr. Arun, and thanks Dr. Arun for all the hospitality and always inviting for the talk. So he got a confusion. I wanted to tell something, he told something. So this topic is into two parts, what Dr. Arun told and what I want to say. So the first topic is on myelocortical MS, which Dr. Arun wanted me to speak, but I wanted to speak something else. So this talk has two parts. One is a myelocortical MS, and then something I will speak on new subtype of multiple sclerosis. So part one is myelocortical MS. The concept of myelocortical MS started with a paper by Bruce Trapp in Lancet Neurology in 2018, where they found in postmortem study of the brain a new type of multiple sclerosis. So I'll talk on that. And the study was conducted in the Cleveland Clinic in USA. There were 100 patients who had died with multiple sclerosis. They did autopsy and took the brain of these patients and then studied from 2011 to 2018. And they proposed a term called myelocortical multiple sclerosis based on findings in 12 individuals, and they compared with other 12 individuals identified as having typical multiple sclerosis. So if you see the scans of these patients, they are clinically and radiologically, you cannot differentiate. So this picture A is typical multiple sclerosis, and picture B is myelocortical multiple sclerosis. So what is the difference? So myelocortical MS, they found that there is demyelination in the cerebral cortex, but not in the cerebral white matter. So what we are seeing as white is not demyelination. What we are seeing as hyperintensity in the white matter is not demyelination. And they also found there is demyelination of the spinal cord. So you have cortical demyelination, you have spinal demyelination, but not in the white matter. So radiologically, what we are seeing pathologically is not demyelination. That is either axonal swelling, free water, microglia, astrocytosis, and serum proteins, which are causing this MRI abnormalities in this brain scan. It's a pathology. First is multiple sclerosis. You can see the demyelinated area. There is no demyelinated area in the white matter of myelocortical MS. It's a normal spinal cord labeled by anti-myelin phospholipid antibodies, proteolipid antibodies, and this is a normal staining. And this is a patient of MS with demyelination in the spinal cord. This is a case of myelocortical MS with demyelination in the spinal cord. And this is a normal brain. And this is the cortical demyelination in a case of MS, and the cortical demyelination in a case of myelocortical MS. And it's labeled by myelin proteolipid protein antibodies. So they found that there is demyelination in the cortex, there is demyelination in the spinal cord, but in the white matter, true MS has demyelination, and true demyelination is not found in myelocortical MS. And they also found that cortical neuronal loss is more in myelocortical MS than typical MS. And this cortical neuronal loss occurs in layer 3, layer 5, and layer 6 when compared to the control brains. And also in MS, they found that the cortical neuronal loss only occurs in layer 5 and not in layers 3 and 4. And cortical demyelinated lesion area was comparable between myelocortical MS and typical MS, while the spinal cord demyelinated areas were more in typical MS when compared to myelocortical MS. So in short, it is a pathological subtype of MS. Till now, we don't know the clinical implications of these findings, where there is demyelination of the cortex, which is comparable to the typical MS, while demyelination of the spinal cord, which is less than that of typical multiple sclerosis, and no demyelination of the white matter. So that is what Dr. Arun wanted to present, and I have presented that. And now we go to the next topic. Next topic is the MS same? What we are seeing, we had demyelinating diseases for 100 years. In 2004, we described aquaporin antibodies. In 2016, we had MOG antibodies. Now, do you have further subdivisions coming up? So I thanked Professor Kadilkar for this topic because he called me to talk on rituximab in neuromuscular diseases. So I was reading literature on that, and then I landed on this autoimmune nodopathy and paranodopathy. I think sir would have going to talk morning. It's an interesting entity because you have central and peripheral demyelination, hypertrophic spinal roots, trigeminal and oculomotor nerve involvement, and they're resistant to immunoglobulin and steroids. Usually, you think autoimmune diseases should respond to steroids and IVIG. And they're very good response to rituximab, which is an IgG4 antibody. This is a case from literature I'll just present. 43-year-old woman with no medical history comes with 3-year history of progressive hand and feet paresthesias and mild postural and head tremor. And the scan is done, and the scan shows, if you show any of the neurologists, they say multiple white matter lesions, and there are some perpendicular lesions, and you have some black holes, and the spinal cord also shows multiple white matter lesions, so they think it's MS. But this patient, they investigated further. They did CSF OCB, which was positive, and they did further studies, and they found that there was hypertrophic roots, and which is thickened roots, and then there is conduction block and temporal dispersion, suggestive of a combined central and peripheral demyelination due to anti-neurofusion 155 antibodies. So this is a case in neurology, neuroimmunology, and neuroinflammation. There's another article in 2022 in Brain Science by Gupta et al., where they reported 7 cases, and one of the first cases was that of a 55-year-old lady presenting with dragging of the left foot for 2 years, Lehermit phenomenon for 2 years, insidious onset and progressive, and the thought of primary progressive multiple sclerosis, and the MRI showed multiple spinal lesions here, and then they did nerve conduction study and EMG, which were unremarkable, and there was no peripheral demyelination, and the serum was positive for anti-neurofusion 140 IgG in the serum. And they described another 2 more cases where there was only central demyelination. There was no peripheral demyelination. So after reading this literature, I started thinking that is our multiple sclerosis neurofusion antibody-mediated isolated central demyelination? And because they're responsive to rituximab, we know that majority of our MS patients do very well on rituximab. So we know that. So that is the same time, there is another personality we should know, Dr. Sudhiran has a lab which is wonderful, and most of us take help from him. Sudhiran started doing neurofusion antibodies. So I just told my patients, I have a hunch that you might be neurofusion antibody positive, and they asked, how do you help it? You're spending some 7,000 rupees, how it help? Well, if it is neurofusion antibody positive, there is no other choice other than B-cell therapy, so your therapy will be tailored to your disease. And as you know that most of our MS patients are affordable patients, and they don't mind spending another 5,000, 7,000 for a long-term disease. So I sent my first patient. So this was the thought, let us check anti-neurofusion antibody in our MS patients. So in our MS cohort, we started, this is one of the patients, I'll just present a 33-year-old RRMS from 2018, paresthesias in the right upper limb. In 2020, left hand numbness and weakness. Patient had partial recovery on Tysabri. This patient didn't recover fully with Tysabri, still had some mild weakness and numbness, but did good with rituximab after the Tysabri. And this is our MRI lesions, which shows multiple lesions in the brain. And you see some confluent lesion here, you can see that. And then this is the spinal lesion. And this is very interesting, because these are all patients with a Moog negative. This is not small lesions of the MS, and not that big as the longitudinally extensive myelitis. And when you do axial section, they occupy the center of the cord. And this patient's NMO Moog was negative, nerve conduction study was normal, neurofusion 155 came positive, neurofusion 186 was negative. This is another case. I will just run a little fast through the cases. So this is another 24-year-old MS in 2022, episode of ataxia and diplopia. She has perpendicular lesions. You can see 1 or 2 there. And these fluffy shadows in the occipital region. You can see a large central in the medulla. And you can see the funny lesion in the medulla. And then this is neurofusion 155 positive. There is no Moog or NMO in this patient. It's another patient, a 30-year-old lady in 2019 had transverse myelitis and unilateral optic neuritis, improved with steroids. And this was at that time, so 3 years back. So we have not seen that. Now, currently, this patient presented with bilateral hand numbness and Lehermit's. And when you do the scan, there is a small segment lesion. She had a very large segment lesion early. Now we have a small segment lesion, and this patient was positive for neurofusion 155. And then we started checking for more patients. And this is another RRMS patient in 2019, burning sensation of the earlobes. 2022, imbalance while walking, given rituximab. You can see multiple lesions in the brain. And then highly classical of MS, and there are some lesions in the spinal cord. She was positive for neurofusion 186. So another lady, 30-year-old with RRMS in 2017, paresthesias in all 4 limbs, on plagridy and tecfidra. Then you can see very geometric shaped lesions. You're like a bullet. Then you have something like very fluffy. and then you have some coin-like lesions and like a tent-like lesions. So very changing geometric shape lesions. Spinal cord, you have a small lesion there, small lesion there, and then this is a little large lesion there, and this is neurofusion 186 positive. This is another patient, diplopia, bilateral lower limb numbness, bilateral upper limb and lower limb numbness, brain is all right, and you can see some lesions in the spinal cord, which is a little larger, and then she is positive for both neurofusion 186 and 140. So this is the data as of March 2024. We have done neurofusion in around 45 patients, 11 positive, 24.4. Then neurofusion 186, 17 out of 23, around 73.9%. Positive, neurofusion 186 plus 140, positive and 71.4%. So around total 44%. This time we started with neurofusion. Then we knew that it is not neurofusion alone. Then we started adding neurofusion 186 and then 140. Now, the last few months, what we have done, we stopped doing this first and going consecutively. We started doing the panel, neurofusion panel we started doing. And this is the data on neurofusion panel, which we have done in 67 out of 260 patients. And then in the pan, at least one neurofusion is positive in 80.6%, 54 out of 67. And the neurofusion, surprisingly, has come down when we started doing the panel. We don't know something with the panel because 186 and 155 can cross-react. And then around 16.4%, 186 and 140 was the majority had 140. And a combined 186, 140 comes to another 23.9%. And rare to have 155, 140 combination. We have done statistics on the clinical features and other parameters, and we could not find any statistical difference in the presentation of these patients. Now, so we also don't know what is the significance of what we are seeing. We know there are some neurofusion antibodies which are being observed in this group of patients. And what else? So we'll just go ahead with a little bit of neurofusions and see whether we have people across the world are having some idea on neurofusions and in MS what's happening. So neurofusions are cell adhesion molecules critical for formation and maintenance of the functional and structural integrity of knots of Ranvier. The work on neurofusion and ankyrin was done by Professor Van Bennett from the Duke Cancer Institute, and there are a lot of papers on neurofusions. And neurofusions are three important types, 150, 155, and 186. They have an immunoglobulin chain, they have a fibronectin chain, and a mucin domain. NF186 and 140 are seen in the nodal or the neuronal, in the axonal part, while NF155 is seen in the glial and paranodal regions. The neurofusion 186 connects to gliomedin and helps to, along with ankyrin and beta spectrin, they cluster the sodium channels in the node. In the node of Ranvier, while NF155 connects to contactin 1 and Casper1, and it forms a molecular boundary so that your potassium channels don't come to the sodium channels. So it's a molecular boundary, and this NF186 helps to cluster. NF186 originates from the axon, while NF155 comes from the paranodal loop. It can be either oligodendrocytes in the CNS or Schwann cells in the periphery. And that is it. And I will not speak more on neurofusions. I think more of you will know. What is NF140? NF140 is the embryonal form. And in the embryonal stages, NF140 comes and works along with 186. But as the brain matures, the NF140 just comes down, and it is more of N155 and 186 in the adult brain. But studies have shown that when there is a problem like demyelination, the NF140 gets re-expressed because all three come from the same gene. And then in the postmortem of the brain of patients with human subjects, they could see NF140. This is a study by Stitch et al. On prevalence of neurofusion 155 antibodies in patients with multiple sclerosis. So if you see the Western literature, they've done 155, which is common in CIDP, and they found that the proportion of patients with MS with neurofusion 155 is very less. So here they did a study, and they found that in around 242 consecutive MS patients, in progressive MS patients, around 4.8% had this antibody. RRMS at 0.6% and healthy controls at 2%. But unfortunately, I feel it is not the 155, it is 186 and 140, which people are not doing, and that's what's important. So are neurofusions pathogenic? Do we have evidence? So this is a paper where from the UK Multiple Sclerosis Tissue Bank, around 14 patients, their lesions there are 8 females and 6 females. The postmortem was done within 7 to 24 hours, age 37 to 77, disease duration of 15 to 40 years, 20 tissue blocks, 32 demyelinating and remyelinating lesions. And what they found that these were the subjects of MS. They died due to various reasons, and they've done the autopsy and taken these lesions. And they found that NF155 at paranodes and neurofusion 186 nodes are disrupted, both structurally and functionally, in these demyelinating lesions. So these are the various, there is an elongation of the node, various abnormalities they have found in demyelinating and remyelinating lesions in both neurofusion 155 and 186. So what they propose with these simple studies on this brain is that this is a normal, you can see the node, you can see the paranode, and these are yellow are the potassium channels, these are the sodium channels. And then what happens is that when there is a demyelination occurs, first the NF155 and the glial axonal junction, there is a problem, and then this NF155 gets disrupted, and these potassium channels will migrate, and they will spread across, and then slowly disrupt the synapse, and then again there is a declustering of the sodium channels, and when there is a remyelination, again the NF155 appears, but it is not as good as that was before. And these are all the various papers which are there. And there's a wonderful paper on neurofusion as a novel target for autoantibody-mediated axonal injury by Mathew et al., which was published in 2007. They found that in their 1/3 of MS patients have neurofusion antibodies, and then they took these antibodies and they injected into the rat hippocampal slices, and they found that these antibodies causes conduction block. And also, Devox et al. From CIDP patients, they took 155 antibodies, and then from these are the patients from they took, and they inject into mice brain, and they find that these antibodies produces intense immune reaction in different parts of the brain. So anti-neurofusion antibodies are known to cause conduction block. They cause paranodal dissection. They cause axoglial detachment. They cause paranodal demyelination. They cause impaired myelination. They mediate non-macrophage-mediated inflammation and impair saltatory conduction and cause axonal disruption. So the expanding spectrum of neurofusion antibodies, you have MS also is coming into picture. We thought it's only some subtypes of MS, but it involves MS, and then along with other CCPD and autoimmune nodopathies. So the spectrum of neurofusions are going to increase, and we are going along with the West or ahead of the West in this. So we don't have much molecular support to know the importance of what we are doing. We don't have animal model labs. People want forward, but it looks something very interesting which we are on. So is this the true Asian Indian MS? So if you see carefully the scans of MS patients, the brain looks like MS, the spine looks like MOG. So there is a subtype of that which are MOG negative and NMO negative, and I think they are neurofusion antibodies. So again, the discussion of whether it's an Indian, we don't know. We have never worked in US or UK to know how their scan will look like and how their brain and spine, we don't know, but it may be something interesting. So the complete workup of a demyelinating disease as of now is not only MOG and NMO. Please get a neurofusion panel, and then be careful whether it is related. It's the first time we are also seeing, so we don't know. We have to see what is happening in the future, and if neurofusions are positive, then we may not give dimethyl fumarate or interferons or something like that. We may go for rituximab and maybe no other DMDs. There's a proposal. We don't know. We don't have evidence. We've not done RCT, but this is a clinician's thought on the things. You may still give Tysabri. We don't know. It may work still. So thank you.